A warm welcome to this End Walk and Wound Ostomy Continence Institute continuing education webinar. Thanks for joining us from around Canada and around the world. My name is John Gregory. I'm a medical writer and journalist, and I have the honour of hosting this webinar brought to you by Ergo Medical and CPIAP, Stop Sealing in the Problem, Advancing Incontinence-Associated Dermatitis Protocols Beyond Moisture Management for Pressure Injury Prevention, and presented by Britney Butt. Before I introduce Britney, I have a few housekeeping items. We are recording today's webinar, so if you must leave a little bit early, or if you know a colleague who would like to take advantage of this education, they can watch it back on demand at their endswalk.ca website afterwards. We'll share that information with you post-webinar. We encourage you to use the chat function in the Zoom toolbar, at the bottom of the screen to let us know where you're from. I'm in Kitchener, Ontario, so where are you? The Q&A function in the Zoom toolbar is also better maybe for posing questions rather than using the chat function. Benoit Garou is also on hand to respond to brand questions in the Q&A. And in the coming days after the webinar, you will receive an email from Enswalk with a link to the feedback survey, a certificate of attendance for today's webinar, and a link to the Zoom recording. So let me introduce tonight's presenter, Britney Butt, joining from LA, California. So Britney is a dual Canadian and American certified and serves as the Wound Ostomy and Care Program Manager at Keck Medicine of USC and focuses on education and research-driven policy development. She served on the Enswalk as an Enswalk at North York General, focusing on providing advanced consultation, clinical program development, and interdisciplinary education. Britney received her master's degree in wound healing from the University of Western Ontario, and Britney has led educational program development, clinical consultation, and research initiatives, implementing 5 national wound, ostomy, and continence programs. She specializes in policy development, pressure injury prevention, and quality assurance audits, ensuring evidence-based care across healthcare institutions. And I also have the pleasure of working with her at the moment on the Enswalk Standards 4th edition. So Britney, thank you very much for being here and presenting. Let me now hand off to you.
Thank you everyone for joining us for this webinar. The title of this presentation is Stop Sealing in the Problem. And I chose this title intentionally because many of the barrier creams, dressings, and treatments currently available for incontinence-associated dermatitis are designed to protect the skin from further exposure to urine and stool. While they can be effective at prevention, they often don't address the underlying damage that has already occurred. That's exactly what we'll be exploring more in depth in this webinar. So this is myself, and I'm currently speaking on behalf of Ergo, but I also am a speaker for Solventum and Baxter. So what do we talk about today? So during this webinar, we will talk about the clinical and organizational importance of pressure injury prevention and the relationship between incontinence-associated dermatitis and the development of pressure injuries. And we'll explore the integration of pure hypochlorous acid into an incontinence dermatitis care protocol for adult populations. So why do we care about pressure injuries? Beyond the human factor, our responsibility to protect our patients' safety and well-being, why do organizations place such a strong emphasis on pressure injuries? And, why do governments prioritize them? And why is there more scrutiny compared to other types of wounds? This is an important perspective for clinicians to understand. When we take a seat at the table with leadership, we often bring powerful patient stories and highlight the human impact of pressure injuries. While this is essential, the reality is that we must also articulate why prevention aligns with the organizational priorities. To drive meaningful change, we need to clearly connect our clinical goals with what matters most to the healthcare organization, our quality metrics, risk mitigation, overall performance. So, when looking at Canada, there was a pivotal moment that came in 2015 when the Ontario government released the Never Events for Hospital Care in Canada list, which identified 15 adverse events that should never occur in our hospital setting. Notably, number 9 on that list was any stage 3 or 4 pressure ulcer, pressure injury acquired after admission. The rationale cited was that stage 3 or 4 pressure injuries can lead to serious complications such as infections of the bone or blood, which is sepsis. Of course, as clinicians, we recognize the complexity behind this issue. There are situations, particularly end of life, where pressure injuries may be unavoidable, and ongoing discussions continue around the concept of skin failure. At the time, this firm stance sparked understandable concern and debate upon the clinical community. However, it also served as a powerful catalyst. It galvanized hospital systems to prioritize prevention efforts and invest in resources and support clinical initiatives aimed at reducing pressure injuries. Importantly, it gave clinicians a concrete authoritative reference to support their advocacy, and strengthening their ability to align improvement efforts with system level expectations and priorities. Currently, the average cost associated with a patient in the United States who develops a pressure injury, which is a stage 3-4, is approximately almost $100,000. If we reduce the incidence of stage 3 and 4 pressure injuries by even like a third, 33%, the projected overall patient costs decrease roughly to $78,000, and that's a 25% reduction in spend. When this reduction is applied across the entire healthcare system, it is estimated that 2.5 million pressure injuries annually that are caused, the potential savings is, 61.8 million per year. And that's nothing to kind of squawk at. So there is a financial benefit to reducing pressure injuries, and really harping on that, I think, really does help when speaking to administrators and coming to them with the concrete spend data. The reality is many of us are working environments where the odds are really stacked against us. We have limited human resources, gaps in education, and no dedicated wound care physician or specialized unit to support best practices. However, there are key variables within our control, and currently many of them are not consistently aligned with evidence-based practice. One of those controllable variables is therapeutic cleansing. To drive better outcomes, we need to shift towards evidence-based products and technologies, not just historical things that we've done. These are not simply expenses, they're strategic investments in the clinical outcomes. And when selected and implemented appropriately, they can work for us, standardizing care, reducing variability, and ultimately improving patient outcomes while supporting organizational goals. So the treatment of pressure injuries is central focus for NSWACs, walk-ins in the United States. In addition, we collaborate closely with our interdisciplinary skin teams and HAPI committees, develop and implement evidence-based protocols aimed at preventing pressure injuries within the acute care setting. There's numerous risk factors that contribute to pressure injury development, including, everything here on this screen, and the list goes on and on. We can go into the multiple factors that influence pressure injuries. However, today we're going to focus specifically on one risk factor, just one thing at a time, and something that is modifiable. I like to talk about the things that we can change. We can't change that the patient is in the ICU, and I can't change the fact they're in heart failure, and I can't change that the patient is diabetic. But what I can manage is their moisture and incontinence. So, and this is a direct link to the development of pressure injuries. So incontinence-associated dermatitis is a well-recognized factor for pressure injury development, and the two conditions frequently coexist in the same patient population. A lot of my pressure injury patients are my incontinence patients, and studies have shown that approximately 21% of adults in acute care setting experience IAD, and 45% of patients with incontinence develop IAD. When comparing patients with IAD to those who develop pressure injuries, individuals with frequent bowel or bladder incontinence are 4 to 5 times more likely to develop pressure injuries. And when I looked at my own hospital organization's data, depending on the prevalence study that we did, sometimes it's 4 times more likely, sometimes it was 10 more likely. They are very, very linked. So how does this apply to incontinence-associated dermatitis? The moisture involved in IAD is not just benign moisture, it's urine and stool exposure, which creates highly damaging environment for the skin. Urine is converted into ammonia, resulting in an alkaline pH that disrupts the skin's natural acid mantle. This shift in pH compromises the lipid barrier, leading to skin cell dispersion and structural breakdown. Once this protective barrier is impaired, it becomes much easier for bacteria from the stool to penetrate the skin, increasing the risk for infection. As inflammation or infection develops, the skin becomes even more vulnerable. The weakened barrier is significantly more susceptible to mechanical forces such as friction or shear, both of which are key contributors to pressure injury development. And compounding this factor, approximately 14% of patients with IAD also develop a secondary fungal infection. So kind of keep that in mind, is that we also have fungus in there, not just bacteria, adding, another layer of complexity and risk. So the same body of evidence that demonstrates the increased bioburden in an alkaline environment also highlights an important opportunity for intervention, targeting pH. By restoring the more acidic environment, we can actively support the wound healing process. In fact, studies have shown that wounds treated in a solution at a pH of 6.0 healed more quickly compared to those treated with a pH of 7.4. This reinforces the concept that pH is not just a bystander, it's a modifiable factor in the wound healing, which brings us to a critical question. If we can effectively address both pH imbalance and bioburden, can reverse the skin damage caused by IAD and ultimately prevent pressure injuries from developing. So incorporating hypochlorous acid evidence-based cleansing into IAD protocols is a topic gaining lots of interest, as most cleansers do not address the acidifying the wound bed and or addressing the bacterial burden from the stool. VASH really checks all those boxes. And now that we have evidence-based product, we need to incorporate into bedside protocols. So how do we do that and why do we do that? So wound cleansing, there's a really big gap that highlights a clear disconnect between the evidence and routine clinical practice. Among NSWACs, 95% report using saline as part of their routine wound cleansing, despite 75.9% acknowledging that all chronic wounds are contaminated or infected with bacteria. On average, NSWACs use 4 different cleansers in their practice, reflecting variability in approach. Compounding this issue is limited access to specialized care. There is only 1.5 NSWACs available per 100,000 patients, and we're graduating more every year, but it's really, really too hard to keep up with retirements. This underscoring the resource challenges that impact consistency in evidence-based wound management. Picture a critically ill patient lying in a hospital bed and supported by, a Foley catheter. They got a central line, and now they have a pressure injury. Every aspect of the patient's care, from the line management to infection prevention, is governed by rigorous evidence-based protocols. Everyone is doing the same thing for CAUTI prevention. Everyone is doing the same thing for Klebsiella infection. When you think of all your protocols for all the different orifices or entry points into the patient's skin, except for one area, the open wound. That's the one where there's so much variability. So while the overall process of wound care might be standardized, the products and techniques we use for cleansing are often not grounded in consistent evidence-based practice. This gap highlights a critical disconnect between what we know and what we routinely do in a clinical care. When evaluating traditional wound cleansers on the market, it is critical to consider the balance between antimicrobial effectiveness and tissue safety. An ideal cleanser must be effective enough to reduce the bioburden while maintaining gentle enough to avoid damaging the healthy tissue. We don't want to be cytotoxic. The latest clinical best practice guidelines emphasize this concept through the lens of what's called a therapeutic index. So you're taking a look at one of those best practice guidelines, you might see that thing of therapeutic index. And when reviewing this, it becomes clear that many commonly used cleansers fall short. They often have a really poor therapeutic index. Either they are insufficiently effective at eliminating bacteria, such as inert products such as saline or sterile water or potable water, or they're so cytotoxic that they damage the host along with the bacteria. When you're thinking of like your Dakin solution or you're thinking of your chlorhexidine. This imbalance highlights a key challenge in wound care in achieving effective antimicrobial control without compromising the body's ability to heal. We can't blow the whole thing up. So these are several clinical guidelines. I'm not going to go into every single one of them, but they're all available for you to take a look at. And I strongly encourage you to review them as they provide valuable support for evidence-based practice, especially when you're trying to introduce this into your facility. It's not just your opinion, it is best practice guidelines, and several organizations have supported this. So limited evidence exists to support the effectiveness of saline in addressing high levels of microbes or bacteria in wounds. An ideal cleansing solution should, instead strike a careful balance, effectively removing biofilm while preserving the integrity of key cells involved in wound healing. Many traditional cleansers, including hydrogen peroxide, sodium hypochlorite, such as Dakin solution, povidone iodine, and chlorhexidine, have all been shown to be cytotoxic and damaging the very cells necessary for tissue repair. In contrast, selecting a cleanser with a pH closely mirroring that of healthy skin can help support an optimal environment for wound healing. So when looking at all the options, hypochlorous acid meets high standards for both safety and efficacy. It also exists at a pH that closely aligns with the healthy human tissue and supported by recommendations in the international clinical guidelines. So, how does it work? How does hypochlorous acid work? Well, pure hypochlorous acid is a substance naturally produced by the human body as part of its immune response to invading pathogens. When pathogens are detected, white blood cells engulf them and generate hypochlorous acid within the cell. This powerful molecule then works to destroy the pathogens. Because hypochlorous acid is already produced by the body, it is highly effective at targeting microorganisms while maintaining a non-cytotoxic environment that is healthy to human cells. In essence, it supports the body's natural defense mechanisms while enhancing antimicrobial activity without harming the tissue it's meant to protect. One of the key advantages to hypochlorous acid is its broad spectrum effectiveness. It has been proven to combat fungi, spores, viruses, and multi-drug resistant bacteria. This antifungal activity is particularly important in the management of otitis-associated dermatitis, where the skin damage is frequently complicated by a secondary candida infection. By addressing both bacterial and fungal bioburden, hypochlorous acid provides a more comprehensive approach to treatment. So kind of getting into the pH of things, healthy intact skin typically maintains a pH between 4.0 and 6.0, creating a naturally acidic environment that supports barrier function and microbial balance. However, when the skin becomes damaged, especially in conditions such as incontinence-associated dermatitis, the pH often rises to 7.5 or higher, shifting that environment into a more alkaline state. This alkaline shift pushes the skin out of its optimal healing range and contributes to barrier breakdown, which increases bacterial growth and delays recovery. Using a cleanser that helps restore the skin pH to a more acidic pH can support the healing process. In contrast, there's other cleansers on the market where a higher pH may perpetuate the alkaline environment, further compromising the skin's integrity and delay healing. So building on that foundation, I'd like to shift our discussion to how you can integrate these principles into current best practices within your hospital organization. When developing an evidence-based skincare regimen, it is essential to consider three key components: the care protocol, the products being used, and the education and competency of staff. To effectively support pressure injury prevention and incontinence management, particular attention needs to be given to the selection of cleansers and barrier products, ensuring they align with best practices and promote optimal skin health outcomes. So when looking at the GEN tool, this was published in 2017 by Dr. Dimitri Beekman, and it offers a straightforward and accessible framework for identifying and categorizing different types of incontinence-associated dermatitis. This tool assists healthcare professionals in objectively assessing IAD. Typically, when you think of your scales, you're thinking your pressure injury scales, and I've seen, sometimes pressure injuries are kind of categorized as incontinence dermatitis categorized as pressure injuries, but incontinence dermatitis has its own scale. So when you're taking a look at it, IAD is into categories based on the condition of the skin. Category 1 signifies that there's persistent redness, intact skin, while Category 2 denotes skin breakdown, open skin. Furthermore, the tool distinguishes between the presence or absence of infection. So Category A indicates no signs of infection, and Category B indicating the presence of infection. Utilizing a P-graph method, the tool classifies the IAD into specific categories, such as 1A or 2B. So if you have a 1A, there's redness, but there's no open tissue and there's no infection. Whereas a 2B, I've got skin loss and I've also got infection. And it really just helps when you can all use the exact same language, just like we do with pressure injuries, with concise assessment and documentation. It also helps with patient management on the flip side. So taking that tool, this is just an example, just again, think about the products that you have, in your particular hospital. But by utilizing the GEN tool, we aligned our products with clearly defined categories, enabling clinicians to select appropriate treatments based on the patient's skin condition. It also is used as a standardized approach across acute care and patient populations. So anywhere that you go within the hospital, you're also going to see the exact same thing, which really helps with your float pool staff. Standardization remains a core principle throughout all aspects of patient care within the organization, including wound management, pressure injury prevention, and skincare protocols. Delivering a consistent message across the organization, it really helps enhance knowledge retention and builds clinician confidence. If you're saying the same thing over and over and over, people really start to remember it. And so while you have these guidelines, if they see the same thing done consistently for the exact same thing, they're really, really going to start to remember. And because really the intent of this tool was not to be used by specialized clinicians. Are NSFOCs really there for all of these incontinence cases? Probably not. Sometimes it takes multiple days for me to get to some of these large cases. I want the nurses to be able to treat these patients effectively before I show up, because I don't want it to get worse over the next couple of days. So really, this tool is not made for you. It's made for everyone else. So, this product, was on the shelf, VASH is on the shelf, and doesn't require special orders for approval. So when you're looking at your IAD protocol, where I find it really, really helpful to add VASH into those protocols is when you have type B infections. So you have category 1B or 2B. So 1B being closed skin, but there's an infection, so you probably have something fungal going on. Or you have a 2B, so it's open skin, and there's also infection. However, it can be used in the other two perfectly fine, from especially reducing that pH, but especially in those fungal, it's really great to use those, especially because when you think of sometimes when we're adding antifungal creams and we have barrier creams and we have powders, we're just adding so much gunk onto the patient. So being able to use a VASH wash is very helpful in those particular scenarios. So I want to talk about a few, little cases here. Some are going to be pressure injury cases, incontinence dermatitis cases, tubular, fistula, and again, you can kind of see the pattern that's going on. So this particular case involves a patient who was admitted into our intensive care unit and experienced a prolonged stay, about 1 month. And during this period, the patient developed a pressure injury due to his declining condition. He was on multiple antibiotics and had liquid stool, which increases susceptibility to a fungal infection. Consequently, the patient was classified as having a type 2B IAD, so you had open weeping skin and you also had signs of infection, which in this case was a fungal infection. So for this particular patient, the patient was treated with a pH neutralizing cleanser, VASH, and our protective cream. Our established protocol also avoided diapers, and that was followed. So ensuring these patients are open, breathable, making sure that we're not having, an occlusive environment. Additionally, the wound also received VASH cleansing and an antimicrobial wound filler. The versatility of VASH proved particularly beneficial in managing the situation because if you had one cleanser for the incontinence dermatitis and then you have to have another cleanser for the wound, it makes it really hard. Whereas when you can cleanse the entire thing, it's just easier for staff and you know that it's going to be safe and effective in both situations. So with this particular patient, the patient was reassessed in 3 days later and the skin damage was classified now as 1A. So we've actually moved through the scale. The tissue had healed and was dry and there was no more signs of fungal infection. Consequently, the treatment protocol was adjusted to our type 1A care guidelines in accordance with the established protocol, but they continue with the VASH washing, obviously in the wound, and as you're washing the wound, they're probably washing the peri-wound skin as you should. So this is a side-by-side comparison illustrating the skin's condition over a 3-day interval, and the patient exhibited noticeable relief from agitation, attributed to the reduction in the burning and itchiness of the peristomal area or peri-wound area. There's many patients that are nonverbal and not able to communicate their pain and not able to communicate how agitated they are from it, and so it comes out in different ways. So in this particular patient, he was much calmer after not just the wound was helping, but that peri-wound, which sometimes kind of gets, it's just incontinence dermatitis, it's just a diaper rash, but it can be very irritating, it can be very painful for these patients. This particular case involves the management of an abdominal fistula. This is actually an abdominal wall, and that area in the center is not actually a stoma, that is a fistula that's stomatized. So this involves the management of, where VASH played a key role among multiple treatment modalities. The patient had a complex 7-month history of an intracutaneous fistula following an anastomotic leak and was transferred to our center for a repair. An assessment of the fistular skin revealed it as a type 2B IAD. There was basically the first layer of skin was completely gone. It was open, weeping. There's definitely bacteria in there. Stool has been in there, and there's definitely a fungus going on. Pouch wear time was limited to approximately 12 hours. That was the max we were getting at the time. So what we did, management included a pH neutralizing cleanser and then also a 15-minute VASH soak. So we took a ton of gauze, soaked it in VASH, and poured that all over her abdomen and allowed that to sit. We also used a fistula management system in place of topical creams to maintain pouch adherence. And following the treatment, so, we stuck our pouch on, we actually got it to stay, and it stayed for 48 hours without leakage. And the peri-wound skin was epithelialized after. You can see what a difference in a 48-hour time frame that we made. And the patient, in that first photo had been living like that for a very long time. As you can see, and for end swaps, you can tell exactly where they were cutting that previous fistula management system. And obviously you can see where we cut ours much closer. So the skin actually finally had a reprieve from that stool touching it. But the VASH really, really helped neutralize that pH, stopping that burn from happening that was going on. This really, really enforces the effectiveness of both complex fistula management and IAD. One of the most impactful changes I've implemented is incorporating hypochlorous acid into ostomy care protocols for patients with, peristomal dermatitis. As anyone who manages ostomy knows, the condition of peristomal skin often has a greater impact on pouch adherence than the actual stoma itself. Once the patient enters this leakage cycle, it can be extremely challenging to break. And In this case, the stoma was fully retracted and positioned within a crease, creating a high risk situation for leakage. And as any of my NSWOCs in the audience know, a retracted stoma in a crease and it's liquid is just like the trifecta of awfulness for that patient. And in this situation, they ended up, in a pretty bad situation, and they presented to our urgent care with significant peristomal damage. Part of our multimodal approach is we incorporate hypochlorous acid soaks to help neutralize that alkaline environment and improve the condition of the compromised peristomal skin. And this intervention supported better skin integrity and helped optimize conditions for pouch adherence. And you can see that 10-day difference. Again, patients still had a long way to go, but we actually had skin that was epithelialized that the pouch could stick onto, and that makes a really, really big difference. In this case presents a similar scenario. While the stoma was less, retracted, it was, small and contributed to significant leakage. And over the course of 8 days, you can see a marked improvement with the peristomal skin was fully healed at the end. And again, we can get a pouch to actually stick to skin instead of being on top of this broken down skin where we're trying to, powder and we're trying to put skin prep on it and everything. We didn't require that at the end, which was fantastic. And this is very, very similar. In this case, you can clearly see that the area which was previously open, the tissue was moist with some depth, is re-epithelialized by day 7. And, I often like to show these more challenging cases because they reflect the reality of practice for NSWOCs in Canada. We're not typically consulted for well-functioning, uncomplicated stomas. We're called when things have already become complex. And in this case, we're expected to quickly assess and correct the issue. And with the addition of hypochlorous acid into my practice, I've been able to manage these difficult cases more effectively and achieve meaningful improvements in a timely manner for patients. This case highlights a common example of peritubular moisture-associated dermatitis, often seen, when a drain has been removed but continues to leak, the leaking persists from the site. And over a course of 4 days, condition of the surrounding skin, demonstrating the effectiveness of, targeting moisture and skin management strategies. But, again, for this particular patient, she had a lot going on with herself. But this tube site caused her the most frustration and pain. The more superficial the wound, that incontinence dermatitis, that moisture dermatitis, that peritubular dermatitis is very superficial, and all of those nerve endings are there. So even if they have something else major going on, they got a large, surgical site infection and it's healing by secondary tension, or they have a large pressure injury, it's those superficial ones that are going to cause a lot of those issues. And so for her, this clearing up this peritubular dermatitis really mattered to her more than anything else in her care. And I'm glad we were able to do that. And we did that with hypochlorous acid. Lastly, this case represents, a mixed etiology wound. While the majority of the damage was related to incontinence-associated dermatitis, pressure was also clearly a contributing factor, and the patient was highly incontinent with type 7 stools. And over a 2-week period, we were able to significantly resolve the skin damage, even while the patient remained in the ICU and continued to have ongoing liquid stool. Unfortunately, diversion with a rectal tube was not an option due to GI bleed. So despite those challenges, targeted skin management, supported a substantial improvement in skin integrity. And so you're able to treat that incontinence dermatitis. You're also able to treat pressure injuries as well. So you don't need different things for those different etiologies, because a lot of patients kind of come with both. You can't really have different cleansers or different treatments. You kind of got to treat the whole thing all at once. So this was able to manage that effectively. So the key takeaway from this presentation is that there are many resources available to support your practice, and hypochlorous acid is one valuable addition to your toolkit. Its versatility allows, you to work in multiple ways and helping restore a more optimal pH environment for the patient's wound or the, incontinence dermatitis, and it also effectively addresses bacterial and fungal bioburden. So, it's a very versatile product. You can use it in many ways, and you know that it's safe. It's safe in our adult populations, it's safe in our pediatric populations, it's safe on all of your body tissues. So as a clinician, I can kind of put it out there, and I know it's going to be used effectively. I know that it's going to be used safely, and I know that patients are going to be treated well, and we're not going to have any adverse events, or we're not going to be killing healthy tissue. So thank you so much for coming to this webinar. And I encourage any questions that you may have, and I'm happy to answer them. Thank you so much.
Brittany, thank you so much for your presentation. It's a wonderful mix of both the evidence and the case studies as well. So thank you. I know that we've had a few questions posed in the Q&A, and I know the team behind have also been trying to answer some of those. So one of the first questions from Fatima is, what are your thoughts on cleansing all the slough with normal saline first and then using hypochlorous acid to soak afterwards?
Yeah, so like, especially being in a hospital system and especially when I have these really large wounds, I am very big on let's give it a lavage. I've got the whole section set up. And depending on where you work, you might not have that. But if there is loose debris, go ahead, clean it with the saline first, and then you can do your vash soak. It's a good economical way of still providing that treatment and just getting rid of sort of that dead debris at the beginning. I do use the vash soaking if I'm kind of clearing away the debris and there's something kind of stuck on. After I do my vash soak, I find sometimes it actually loosens it off. But clearing it out with saline first and then doing your vash soak, it would be completely fine and an economical way to approach that.
Okay, there's a question in terms of would it be hypochlorous acid? Would it be suitable for pediatrics? But what about neonates or newborns?
Yes, yeah. So at Tech Medical Center, we don't actually have a NICU, but at my previous organization, we did. So it can be used on that patient population as well. And that's also why I like it. We had it in our ER, we had it in our NICU, we had it in our labor delivery. So it's a very, very effective, but also safe treatment for all of your populations, 0 to 116.
Yeah, and we
Okay,
we also have a
sorry, Benoit.
oh, sorry. No, sorry. I just wanted on the pediatrics and neonates, we have a new study, a peer review study that we can communicate to NSWOC and you can send to everyone.
Benoit, thank you for adding that. Brittany, again, Daria asks, in the first case study, how did the wound respond? Wouldn't no rinse foam cleanser be as effective at managing pH balance?
Yeah, so in that particular first case, there isn't a follow-up because the patient did pass. Again, I got some relief when I came to that incontinence dermatitis. However, there wasn't a follow-up picture because it was an intensive care patient and they did end up passing. So in other cases, the wounds respond very well, and I have case studies on that, but not that particular person. And then with the no rinse foam cleanser, so you can do that. Again, the pH is a little bit different, but it's not addressing your bacterial or your fungal. So in that particular case, you can use your no rinse cleanser to kind of get rid of all the debris. So, if your patient is covered in stool, you're not going to just go in with your vash. You can go in with, your no rinse cleanser, get everything off. You want that surfactant. And then you're going to do your treatment on there. It's really going to reduce that pH, but it's also going to treat any bacteria or the fungus. So they do just something different, not necessarily comparable, just different things. And you can use them in conjunction with each other.
Wonderful. Julia asked, should we use hypochlorous acid soak compress for 5 to 15 minutes or just use a cleanser? I think she means for incontinence-associated dermatitis.
Yeah, so, it's funny when you play this game with your policies and procedures. When you ask for 10 minutes, know that you're going to get 5 minutes. And you ask for 5 minutes, know that you're going to get 1 minute. So I usually will write down, do a 5-minute soak. But whatever they can get on the patient would be fine. And actually, we still see results in that. Fully understanding everyone has probably turned a patient and the patient is can't be turned very much because the patient's unstable or the patient is wiggling around. So I do recommend if you can get at least 5 minutes, that's great. Turn them over, put that on, do whatever you need to do if they can stay. But if they can't, whatever you can get is always going to be better than nothing, because as soon as it makes contact with the skin, it's going to start reducing the pH and it's going to start killing the bacteria right away. So it's my orders over the years have changed, and it just depends on what group of nurses I'm working with.
Yeah, I've seen actually a number of comments or questions with regard to that kind of time in terms of 5, 10, 15 minutes and so forth. You also earlier mentioned about therapeutic index, which might be I guess a new topic which has kind of really come up in the last 18 months. I don't know if can you expand on that a little bit? That might be new to people.
I think, that's a great question. I don't think I'm the right person to talk about it, but the great people who put together the wound infection guideline and together the wound cleansing guideline, they were able to go in and take a look at the literature. And basically the therapeutic index is just, how much does it kill the bacteria? How much does it damage the cells? And having a ratio of that. There's a great talk someone does, but I don't think I'm the best person to talk about it. But if you take a look at the guideline, they fully explain it.
Okay, wonderful. Thank you for that. We can point, and I'm sure Ergo Medical can as well. One question: any recommendations for alternative products that can affect skin's pH for areas that are remote or not within an organization's budget?
I can't necessarily talk about that only because I don't necessarily know what's available in certain regions. So what I would suggest is you reach out to your product representative to see where it's available. I know that there's other ones in the market, but I just don't know who sells where. So that would be that I don't know where things are necessarily manufactured or distributed, unfortunately. But I would reach out to the company to see.
But I mean, I think it's a good question because, there's been lots of literature about low resource environments and settings. And if you don't have access to products, then what alternatives are available? There's two questions here, which are essentially somewhat the same in terms of the interactions between hypochlorous acid and either iodine-based or silver-based antimicrobials. Can they be used together? Can you expand on that?
Yeah. So not necessarily soaking it. So a really good one is like hydrofera blue. Someone will come in and they'll accidentally soak the hydrofera blue in VASH and it'll turn white, and that's how you know. Some of the other ones aren't going to have a color change, so it isn't going to be as much of like a hay. But don't, unless you're soaking gauze in VASH, don't soak anything in VASH. It's not going to be compatible. You can clean the wound though. Just make sure the wound isn't full with fluid when you stick that in. Pat it dry. You don't have to rinse it out by any means. If you just pat it dry and then you put your antimicrobial, then it's going to be compatible. But definitely don't soak anything other than gauze in VASH. But you can use it in conjunction as a wound cleanser if you need to.
Okay. So another question in terms of what are your thoughts on triad cream as a barrier after hypochlorous acid wash?
Yeah, if that would be applicable. So the nice thing with the VASH washing is what you're trying to do is you're trying to reduce the pH, reduce the damage, and then what the triad's trying to do is help protect. Remember again, this is kind of going off the thing about VASH, but just remember with triad, don't put it everywhere. The worst thing with triad is it becomes a whole cement, but be very, very particular about your application over just those spots. So if you're using it as a barrier product, like as a general barrier product all over the place, I would not recommend it. It creates cement. Use more of like a dimethicone, and then you can spot treat with your triad, but try not to put it everywhere because you get cement.
Okay, and a question about frequency. I mean, if you're seeing a patient daily, would you use hypochlorous acid daily with a patient?
Yeah, absolutely. The nice thing, there isn't like a maximum. There isn't. There's certain products have like a maximum amount of like that you can use it, but VASH doesn't have that. So you can use it every single time that you see the patient if you still feel that it's clinically needed or necessary for that patient, but you're not going to overdo it or have an absorption rate and having to worry about systemic uptake. So you can use it each time. So in my practice, I would.
Thank you, Brittany. But Benoit, I know that you and your team have been answering some of the questions in the background. Were there any that you wanted particularly to pose to Brittany or ask her opinion on?
Hello, sorry. I think we received a question like how does pure hypochlorous acid actually fit into an existing IAD protocol? Does it replace our barrier creams? And how do we need to rinse it off? And do we need to rinse it off?
Yeah, so it doesn't replace your barrier product. It kind of like works upstream of it. So the sequence is you're going to do your cleansing first, and especially if the patient has a lot of stool, you can use whatever cleansing product that you have. Hopefully it's a no rinse cleanser. Hopefully it's a pH neutralizing cleanser. Every place is different. Sometimes they're better than others. But get rid of whatever stool, whatever urine is there. Get your bulk. You don't have to necessarily use the VASH for all of that. Again, trying to be economical. You're then going to do your soak. So if you have incontinence dermatitis, if you have skin breakdown, then you're going to do that. If your skin is clear, go right to your barrier product. But when you have those issues, that's when you're going to do that soak. Once you're done that soak, you don't have to rinse it off. You can then put whatever barrier product over top. Something with a dimethicone is preferred. Again, it's skin friendly and it's going to allow moisture transfer through, but also a nice barrier. So it can be used in conjunction. The nice thing with the VASH is that it actually kills the fungi. I had said previously, the fungal infections can become very, very frustrating. Again, now you have your antifungal cream, now you've got your barrier cream, and it just becomes this big issue. One of the ones that is the most issue is actually under flanges. So if anyone's ever treated an ostomy and then you have a fungal infection and then you have like a physician ordering an antifungal cream to go underneath the flange, like it doesn't really make sense. So the nice thing with the VASH is that it can actually kill that fungus while again, you're not having a cream or ointment, then you can get the flange on it. But it's non-cytotoxic, so you don't have to rinse it off before you put on your barrier cream. So you can use it in conjunction into your protocols. But you don't necessarily have to use it to clean all the stool off. Do that with your regular products and then get your VASH on there.
Thank you, Britt.
Okay, thank you. Yeah, thank you. Appreciate it. If I understand the question correctly, it says, what do you think about marathon protectant on incontinence-associated dermatitis? Have I understood that
Absolutely.
correctly?
So, and I'll instead of using the brand, I will use the generic, which is cyanoacrylate. So Marathon would be a cyanoacrylate. You can use that as well. Be mindful on fungal though, because it is a very thick barrier and you are going to seal it in. So really treat your fungal first before you go in there with the cyanoacrylate. Cyanoacrylates can last up to 7 days. That doesn't mean they do last 7 days. So just keep that in mind because I know that a lot of times, oh, it's a 7 day wear. But like anything, again, I go right back to ostomy with a 7 day wear flange, or if you go to a sacral foam, okay, it can last 7 days, but does it last 7 days, right? So use your judgment. You'll notice, especially with one brand, it will stay purple. When the purple's gone, you know it's gone. With another brand, you know that it's shiny. If it's not shiny anymore, it's gone. And then that's when you can treat it with more hypochlorous acid. So you might reduce your frequency based on the cyanoacrylate, but please wait until your fungal infection has resolved before you're putting on the cyanoacrylate. Just kind of little things that you can do, but it's compatible.
Okay, thank you. Actually, in the chat, there was a comment in terms of hypochlorous acid compress versus cleaning. Can you discuss that?
Yeah, I prefer. So it's all about the preference. My patients, there's the way I'd like to do it, and there's the best practices, and there's what you can do. And I'm very big in just the reality. If I had my choice, you'd probably sit there for 10, 15 minutes with a VASH soak while I prepare everything else. And that's enough. Again, if I have a patient, they're in the ICU, it's an abdominal wound and they're sedated, it's probably going to work out really well. However, if you have a patient where you get 5 minutes, that's all you got, and you then go with the cleansing if you can. Something is always better than nothing, and I'll say that about most things. My preference is the longer the better, not even from the pH or the bacteria standpoint, but even from a debridement standpoint, you're really going to loosen up those fluffs and you're going to loosen up those bonds. So the longer you do those soaks, when you take that off, you're going to be lifting up more dead material. So it really does support debridement as well. Again, that's apart from the IAD protocols. So the longer you can get, the better. But again, recognizing that if you can only get a cleanse, then that's what I can get. And there's some patients where all I can get is a cleanse, and we do that.
Thank you. Actually, I have a question.
Yeah.
So in your presentation, you were talking about wound cleansing gap, evident versus routine practice. I would be very interested in the references to those statistics that you had, and maybe either you or
Yeah,
Ergo
we can
could
provide them.
provide those. I would be very interested.
Yeah, we can definitely. Yeah, we can provide those. Yeah.
Benoit, was there any questions that we haven't adequately answered already?
No, I think we are good. Thank you.
Yeah. Well, I want to say thank you everyone for joining. Incontinence dermatitis or just moisture dermatitis in general, it's one of those things that kind of gets pushed aside. But when we bring it back to pressure injuries, and that's what I typically do, if you can link it to pressure injuries, you can get people to care about it. And when you get people to care about it, then you can get the things that you want from an administrative perspective. You know, when I walk in and if I start talking about quote unquote diaper rash, you can see everyone's face sort of like stop caring for a second. But when I do link it to those pressure injuries, and it does happen, you can see that kind of their ears go up a little bit. And when you can prevent or treat and manage incontinence dermatitis, it will directly impact your pressure injury prevalences. So when you can link that for them, I find people start caring just a little bit more, especially again, you're non-clinical, the ones who don't understand what hypochlorous acid is, who don't even know what pressure injury stages are, but sometimes you do need to get them on your side, even though they really don't know what you're talking about. So if you can link it, I find it helpful.
Okay. Thank you, Brittany. Benoit, anything you wanted to add by way of wrap up?
No, thank you so much, everyone. And thank you, Brittany. And thank you, Enswalk.
Okay, you're great. So first I would like to thank our presenter, Britney Butt. Thank you. So you will receive an email in the days after the webinar with a link to the survey about the webinar, a certificate of attendance, and on-demand link to access the recording. Thank you to Troy Curtis and the ENDSWalk team, as always. So I'm John Gregory on behalf of ENDSWalk and the WOC Institute. Thanks to our speaker, Britney Butt, and sponsors Ergo Medical and TPIAP. And for you for attending. Thank you. So that concludes our webinar series for the spring and summer. We resume with more webinars starting in September. We look forward to seeing you there. So thank you all very much. Good night. Thanks, Brittany. Thanks, Ben.
Thank you.